My name's Ernest Hunter. I'm a retired psychiatrist, but I've spent my whole career working in remote Indigenous populations. And one of the issues that I noticed very early on was that the patterns of psychiatric disorders and behavioural issues in the populations that I was working in were changing. In order to understand that, 30 years ago in the Kimberley, I sought to try and identify historical trends. And in looking at suicide and also deaths from non-natural causes, it seemed there were significant changes over time which tracked back to periods of substantial disruption in the lives of Indigenous people in the Kimberley that were associated with demographic changes, economic changes, the dislocation of people from pastoral properties and elsewhere, and entry into a cash economy which translated as a welfare-dependent economy, into which was added alcohol. That's in the early 1970s. The consequence of that was that over the next decade and a half there was a dramatic increase in the deaths of young adults from non-natural causes. These young adults were also parents. 15 years later, we saw a very dramatic increase in suicide amongst young people who were the children of that first generation to be exposed as young adults to that turmoil. I think what this indicates is the salience of the early developmental environment, the emotional and social support and consistency that's important for optimal child development. However, we also know that there are internal changes, and at the same time that I was doing my research, another researcher, Link Schmidt, was looking at catecholamines and corticosteroids, stress hormones. And one of the things that he noticed was that those levels were extremely high and appeared to be correlated to the welfare cycle. That is, that the structures that we had put in place to support disadvantaged people were causing episodic periods of stress that was impacting everyone in the community and every person who was pregnant in the community. So antenatal development was probably being impacted. That research was done in places where there was no alcohol. And the mediating behaviour at that time was probably gambling. 20 years later, I've sought to look at whether there are similar patterns or changes in the development of other mental health conditions. And with my friends, Bruce Ginther, Fiona Charlson and others, we've taken a unique database that was set up in 1992, which includes all of the clinical documentation of individuals with psychiatric problems in Cape York, and which continued until 2015, and we've looked at changes over time. What stood out is not only that in terms of serious mental illness, which we often think is independent of the vicissitudes of social change, etc., we have levels of schizophrenia and related psychotic disorder that are significantly greater than in the wider society by several orders of magnitude, and also that difference is not equally experienced across remote populations. In particular, there is a dramatic difference between the rates of psychosis in Aboriginal people in Cape York, all of whom were exposed to particular draconian controls through missions and government settlements, and a period of enormous instability which continues but started in the 1980s. Their rates were very high compared to their equally remote Indigenous populations in the Torres Strait. Significantly, that period of change was not felt to the same way in the Torres Strait. And indeed, even before the 1980s, Torres Strait Islanders were not removed from their land. They were able to engage with the wider society in relation to the economy and employment, and their experiences were quite different. So that again indicates to us that we need to think about the historical antecedents of those changes. And indeed, we think that we have identified a cohort effect. That is, amongst those people who were young adults who were children, I should say, at the time of that period of dramatic social turmoil. 20 years later, it is that group who have demonstrated the much higher rates of psychotic disorder and carried that with them into older age. The implications of these issues, and there are other matters that we could relate about the finding, but the implications of these are severalfold. One is that in understanding patterns of mental health disorder in these populations that are significantly different to the wider population, we need not just to look at what the social circumstances in those settings are now. We need to ask the question, how did they get this way? What were the policies and practices that informed those increases and the differences across populations? Secondly, we need to ask the question, how did those events impact group and individual mental health? We would argue that the mediating factor is through their impact on the neurodevelopmental environment from pregnancy through early childhood. And that's a broad and sweeping arena. It includes the interpersonal, nurturant, attachment issues, but it also includes the internal milieu, the ways in which stress hormones impact neurodevelopment, and the ways in which they set up vulnerability not just to the development of serious psychiatric problems, but to the development of a range of conditions to which Indigenous people are disproportionately vulnerable, including cardiovascular disease, diabetes, and all of those issues. I think then that in terms of policy, although we don't necessarily have the answers about what to do, probably the most important place to do it is in pregnancy and early childhood. And to the extent that we can invest money in prevention, early intervention and identifying people who are about to become psychotic is useful, but we need to shift it a lot further forward and continue the investment and expand it in early childhood, in pregnancy, and importantly in relation to particular outcomes such as suicide, maintaining the integrity of families. And despite children no longer being taken away by the state in the ways that the stolen generations were, children are being removed at the same rate overall to child detention, and keeping kids engaged in school. These are just really critical issues. And I might say that as we looked at child suicides a decade ago here in Queensland, three things stood out. That those children who died weren't in families, and they weren't in schools, and they'd been exposed to self-harmful behaviour. The latter had never been experienced by their parents and grandparental generations, and the areas that we have probably the most easy access to make a difference is around the school setting and supporting early childhood.
So you are retired now and you have worked in this field for a long time. We're seeing some targeted interventions now in the Kimberley especially. Are you optimistic that practice and policy is heading in the right direction?
I'm optimistic for a number of reasons. One is we now have a significantly greater number of Indigenous people who are driving this process, and that's really critical. Secondly, we do see some changes in some of the indicators in terms of health, and from our data we have seen for those people who have been diagnosed over the last 10 years or so, they are much less likely to end up in prison, for instance, than was the case of those people diagnosed before. That may relate to differences in the justice system. It may relate to differences in the ways in which we get services to people. It may also relate to contextual issues. In Cape York, that includes the availability of alcohol. That's a complex issue because we then get into a discussion about rights. In that regard, I'd say that we need to think about positive rights and negative rights. That in terms of the availability of alcohol, there are rights for people to be able to have choices in that matter, there are also the rights of infants and children to environments of protection. The situation is somewhat different now because during the 1980s there was an invidious nexus in which communities in which people lived were the beneficiaries of the sale of alcohol. That then put those people who supposedly had the best interests of communities as their driver as the people who benefited from the sale of alcohol. That doesn't exist now, and I think that we have better systems of governance across communities and capacity to be able to make those decisions, and at the same time to consider the means whereby you can ensure that there are protections and appropriate approaches to controlling those issues. Unfortunately, in remote Australia, we're now also seeing the arrival of a lot of other substances. We demonstrated in our data, and I haven't spoken about that today, how the reduction in the salience of alcohol in terms of the presentations of people with psychosis fell after alcohol restriction was put in place, but cannabis use increased in its relevance. The two have certain differences, though, one of which is that although alcohol was certainly involved, a dramatic factor in terms of a contribution to people with psychosis ending up in prison, cannabis isn't so much. It has other deleterious effects in terms of resource diversion, in terms of its impact on the development of psychosis. It's less salient in terms of the sorts of things that get people in jail. But I think we also need, when we see differences like have been demonstrated between Cape York and the Torres Strait, to really ask, well, what are the differences in the social environments in which those issues are occurring?
And we're about to get booted out, I think, for the next session. So if I could just ask you one more question. You're wearing a Stop Adani t-shirt. What are you looking to from the federal election, and what are your hopes?
I hope people take seriously the risk to the reef and the risk to the environment. Our Indigenous, the Indigenous figure who welcomed us, Professor Marie, pointed to the dangers. I have spent the last 20 years kayaking the reef. I've kayaked the entire reef, most of that many times. In that time, I've seen the devastation. I've seen the reefs disappear from around Lizard Island. I think as a health professional, I have always thought that we should take a precautionary approach. I don't think we need to wait for the end to say that whether we have all the data in, and most scientists would agree that we should be acting anyway, that we should be taking concerted and radical action. And I think radical action includes eliminating our dependency on coal. And I don't think that we should be increasing coal mining, which I think is driven at the moment by a sense that because it's going to finish at some point, let's dig up as much of it as we can and flog it off overseas. It demands radical action. If there's radical hope for climate change amelioration, it requires radical action.
And is this an important thing for psychiatrists to take into consideration?
I am not representing the Royal College in saying this. I'm representing myself. But I think all psychiatrists should think about the environments in which the next generation are going to develop, and this is having consequences for all of us, and I think we need to be blind not to see that there is a role for people in positions of leadership and responsibility, not thinking about the ways in which it impacts our fields.
Thank you very much.